All right, so today, how will the ACA, the Affordable Care Act, affect your patients and your practice? We've got a panel of experts here, Ken Peach, Mitchell Gordon, Michelle McCormack. I'm going to introduce each of them at this time. Mitchell Gordon, he's one of our members. He's also owns and operates Gordon Contracting for over 35 years. He used to build things. You probably tore them apart before you built some things too, right? But he's in a whole different kind of business after 35 years in that business. He's a certified independent licensed insurance broker for over 15 years, specializes in Medicare, Medicaid, education, and has done extensive research on the Affordable Care Act. He works with physicians and practice managers to help educate their patients about the many health plans. Seminars he provides to church groups, associations, schools, and the like. He's been living here in Central Florida for over 42 years, married with 4 children and a grandchild. You went to Nassau College. That's somewhere up in New York. Are you a Yankees fan? No. That's the wrong answer today.
When Mickey Mantle played.
Some interesting things about Mitchell. He's a writer of political satire and published author of romantic poetry. Can I put you on the spot now for something?
What?
Poetry.
I had a writing partner, and she thought I was a plagiarist because I could not remember any one of my poems. So no, you can't.
Okay, I'm not putting you on the spot today. How about that? He likes rollerblading, cycling, working out the gym, rock and roll music, absolutely, and likes to parachute jump and whitewater rafting. Who would have thought? Welcome, Mitchell Gordon. Please. Now, Ken, you're kind of fortunate because there's nothing on here that's funny yet. So I'm going to have to draw that out of you. Ken Peach is the Executive Director of the Health Council of East Central Florida. He's spoken to at our meetings before, and we're just so happy to have you here as well. At the Health Council, they're in charge of planning here in Orlando and the Space Coast. I asked him how many slides he has up there because he's got so much information. We could watch bar graph after bar graph, pie chart, to see the statistics of how many people are sleeping in the hospital beds at night or being treated for different things. So it's a great organization. Before joining the Health Council in 2010, he owned a medical practice business, development company, and health insurance agency. From 1985 to 2005, he was an administrator in hospitals, health systems, senior living facilities, and for 2 years he served as the American Hospital Association Regional Executive for Florida and Puerto Rico. Vice President of Integrated Delivery Systems with the Florida Hospital Association. Ken began his career in New Jersey and Florida, building, managing, and owning AM, FM radio stations. So what's your favorite musical genre?
About as far as from Mitchell as we can get. Easy listening, classical music, jazz.
Oh, he's smooth, All right. I'm still right here with Mitchell, though. Ken holds a BA in communication degree from Seton Hall University, an MBA with Health Services Administration degree from Florida Institute of Technology, a fellow in the American College of Healthcare Executives. He's married to his wife, Ann. They have 3 sons. They live here in Orlando. And tell us then what funny fact or hobby that you have that we would not expect you to have.
That's an easy one. The first Thursday of every month, you'll find me on the beach at Cocoa Beach with a metal detector. I'm an electronic beachcomber since I was a kid. So don't ask me what I found. I got a box, but yeah.
He found a box. Thank you. All right, and I have some fun facts on Michelle, so she doesn't have to, and she's wondering how. It's an electronic world out there. I'll tell you what I found out in a moment. Michelle McCormack has a broad background in clinic management, nursing, aesthetics, massage, wellness, and insurance. She runs the operations and management of Aviva Healthcare. She holds a BS degree from UCF and an MBA from Wharton School of Business. She's nationally accredited and licensed massage therapist, certified medical electrologist, licensed medical esthetician. Esthetician. Oh, man. These people from Boston don't know anything. RN and certified in all laser services. And now some of the fun facts I found. Let's see. Surfing and biking We can see you out on the trails here in Orlando, and this really caught my attention. Congressional Order of Merit recipient in 2008. Who do you have to bribe to get that? Now, I'm just joking, but please tell us a little bit about that.
So in 2008, I started a foundation for healthcare for uninsured people. So it was a voluminous task to start out with, but it was something that was a big push with the local government. So we started that. We have a bus on the roads that goes to various different communities that feed into emergency rooms that have very low acuity that go into emergency rooms for splinters that were bogging down the emergency rooms. So that was the reason I got that.
Well, congratulations on that. Let's give a warm welcome to Michelle. Questions will come at the end of each presentation or at the very end?
Whatever your pleasure.
Okay, well, we'll see how things are going. We'll just go with each presentation. Take your questions down. You've got more of notebooks in front of you so that you can write down the name of the presenter and what questions you have, and hopefully we'll have enough time for audience participation. Mitchell, you're going to get us going.
Yes.
Please do.
Good morning. I started going to seminars like this about 9 months ago, and the first one I went to was at Seminole State College. They went into everything. It took about 4 or 5 hours. I know you want to get home before dark, so I'm not going to do every single aspect, okay? I'll start off by telling you what we're not going to talk about. SHOP, the Small Business Health Option Program, and anything to do with the commercial end, because they've postponed it, and they've waited on it. And so if you have any questions about that, I can speak to you after the program, okay? I was at an ACA seminar last week, and it was national speakers. It was an ex-congressman. It was people who affected the policy. And while they gave great information, I asked all the people at my table, some of the people at my table, yeah, they understood it, but there was no relevant information for them for day-to-day access about what this is all about, okay? Last week, I spoke to a woman, and she says, Mitchell, I want an individual issue insurance for myself, but I don't want Obamacare. And then I spoke to a gentleman who's got 5 stints. This is a man who could never get insurance in his life. And he refuses to get insurance because it has anything to do with Obamacare. And you know the expression, bite your nose to spite your face? This is what the law was made for. It was made for people like him. And herein lies the problem. Health care, health insurance, and the PPACA, Patient Protection Affordable Care Act, affectionately known as Obamacare. Those are 3 separate individual things that are all intertwined. Health care, very simply, go to your doctor, you get health care. Health insurance is what pays for it. The Affordable Care Act is the law that mandates what the insurance company has to give you. You're not buying Obamacare. You're buying health insurance from an individual company, okay? The mandate is, there's some good stuff in there. It's on your handouts. By the way, the handouts have some statistical information. I'm not going to go into heavy statistics. I'm just going to refer to it when necessary. If you have a pre-existing condition, does it make a difference? You have a maximum out of pocket no matter what happens, and it's got a certain level. If you cost $10 million to cure you, doesn't make a difference. You're covered. So those are some good things that are in the plan, okay? For some of you, this will just be a repeat, but for many of you, it's going to be something new and that you haven't used to. And to paraphrase an associate broker, Greg Rodriguez, it is now, it says to look at my watch too, it's 8:15. Everything I tell you is true as of now. By the time you have dinner, it might not be. Not that that's a bad thing, it's just there have been 35 changes and 29 postponements, okay? And again, things change, things evolve, okay? I will look at my notes so I don't miss something for you, okay? There are different levels of coverage. There are 5 levels. I'm not going to get into the first level, the catastrophic. If you're under 30, or if you're over 30 and have special circumstances, you qualify for that. There's always going to be exceptions, by the way, to what I'm talking about, each thing. There's the bronze, the silver, the gold, and the platinum, okay? Each level has different programs in it, okay? The most that you can pay out of your pocket, as I said, $6,350 on any plan, no matter which plan you have. That's part of the mandate, okay? Now, platinum plan, most expensive, top tier. You might only have a $1,000 maximum out of pocket. You might only have a $1,000 deductible. The bronze plan is the lowest. You might have as high as a $6,000 deductible and a $6,350 out of pocket. which means you go to the hospital, you don't particularly get served. You'll get served, of course, but you have to pay that $6,000 first before they take care of you, and then the company starts paying. One of the advantages of the Act is the deductible counts towards your out-of-pocket. Years ago, and I felt bad for people, years ago if you had a $6,000 deductible and a $6,000 out-of-pocket, you were spending $12,000. Now if you have a $6,000 out-of-pocket, it counts toward, deductible, it counts towards your out-of-pocket. So it lessens the burden, okay? Which is why the insurance got more expensive, and that's understandable, okay? And as with all laws, some people are against it and some people love it, okay? I can tell you with 100% surety of all the people I've spoken to, if you're getting a subsidy, you're going to be very happy. If you're not getting a subsidy, you're going to be a little sadder, okay? There are many choices of plans, okay? Every time I speak with people, it usually comes up there's between 70 and 120 choices. And the basic differences are just price, okay? Give you an idea, I have a gentleman who's 30 years old, and he makes $12,000 a year. His premium is 90 cents a month, okay? His deductible is only $500. His maximum out-of-pocket is only $12. Do you think this guy is happy? He's thrilled, okay? I have a couple who are in their 50s. Their premium is $3 and approximately 36 cents. Their premium actually would be $1,190-something, but the government is subsidizing the difference, okay? This is good because a lot of these people, this gentleman, the young man, he can't afford insurance, and he's healthy, so he might not need a lot, but he's got the help there now that if he needs it, okay? If you do not fit into the financial category, okay, you do not get a subsidy. And I'm going to tell you the categories in a minute. The subsidy, if you don't need a subsidy, we'll start with that. You just take you and your agent, go to any insurance company, look up the plan, pick it, and buy it. You do not need to go to the government website. Okay, it's that simple. The ranges are this, and I'm going to approximate because I see different figures all the time. The range for a single person, I hope I'm close enough. The range for a single person is between $11,500, that's 100% of the poverty level, to $44,000, that's 400% of the poverty level. If you're above that, you're not getting a subsidy. If you're below that, you're not getting a subsidy either. You would normally qualify for Medicaid. But Florida did not take the government money, so if you're a single male, probably female too, and you're under 65 with no major disability, you're not going to get Medicaid. It's impossible to take care of every single person every single time. There's always going to be someone who falls through the cracks. That's the person who does, and it drives me crazy. I work as hard as we can trying to figure out something to do with them because if you're making $9,000, you can't afford a $5,000 a year insurance policy. So what do? You go to the emergency room, which is what this was made to prevent, okay? Remember, going to the exchange and off the exchange, your policies are the same. If you have policy ABC from company F, and you go on the exchange or off the exchange, the policy is going to be the same, okay? The only difference is the subsidy from the government. When you go to your doctor, you don't have to tell them, I'm on Obamacare. You're not. Remember, Obamacare is the law. It's not the insurance. Your doctor's not going to care who is subsidizing you and where the money's coming from. The doctor just looks and says, you have insurance. I think I can treat you, and we can afford to do everything, okay? So that's what happens when you're off the exchange, that you do not get a subsidy. And let's look at what happens when you're on the exchange. And again, you've heard this in the news. I can't vouch for the security of the website. I don't know anything about that. But there's no information that you're giving the government that they don't already know, okay? We've already plugged in people's income and how much they're going to make and how much they think they're going to make, and we've got it kicked back within 3 seconds asking other questions because the government computers are just going from one computer to another, sharing information and telling us, okay, you made a mistake, you didn't add this in, or you added too much. Okay? Everybody's guessing, by the way. You're going to tell them, when I sit down with someone, I have to ask you how much do you intend to file for taxes in 2014. Well, you don't know. You won't know until next March. Next March, 2015. Everybody's guessing. So if you guess, and you tell me 20,000, and you make 30, the government's going to send you a bill for a couple of dollars. If you tell me 30 and you make 20, they're going to send you a refund. It's that simple. And that's why they did it through the tax system. So they'll have, you have to file a tax return, by the way, or they're not going to give you the subsidy. That's the only way they can check what's going on with it, okay? So, there's also, besides the subsidy, this share of cost. A lot of people don't understand that there's extra things there. Share of cost is when they will help you pay for your out-of-pocket and your deductible, okay? Again, I don't expect you to remember all the figures, but between 100% and 250% of the poverty level is the magic number that you get a share of cost. And it is very important, and here's why. If you have a $50 silver plan, and you look at the bronze plan and it's zero premium, which is very possible, you're saving $600 a year, which to a lot of people is a lot of money. But your share of cost does not exist in the bronze plan. It only goes for the silver plan. So the silver plan share of cost might say, okay, we're going to take your $6,000 deductible and turn it down to a $1,200 deductible. But if you go to bronze, you do not get that. So that's why you want to stay in that one silver. If you go above to gold and platinum, you also do not get the share of cost. And there's a big difference, because if you have a $30,000 bill and you hit the maximum out of pocket, you can have a $6,000 out of pocket, or a $900 out of pocket, or a $1,200. So in that instance, it makes a very big difference, okay? Again, they will check you to see if you match your income, what you said, when it comes to your deductible and your out of pocket. And if you made a mistake, they're not going to come after you for fraud. They will just either send you a refund or send you a bill. But the share of cost is not auditable as of now, as I said. So even if you made a mistake and you got the advantage of it, they cannot do anything about it, and they will not do anything about it. They will not audit that part of the way of it, okay? The only self-serving thing I'll say for myself and agents is, when you call up the government directly, you're working with navigators. They were not allowed to have any insurance experience, okay? They could not work for an insurance company. They can't be getting commissions or have any affiliation, okay? So there's a difference, because they're looking at a form. By the way, they're very polite. They're very helpful for what they know, but they only know what they're looking at on the form. I did two yesterday. One gentleman that's a member here, Dan, and they just couldn't find the information that we'd already given them, or Dan already gave them before a month ago. They couldn't figure it out, and they only know what's on that form. If you have a special need prescription, and it's better for you to pay more premium and less money for prescriptions, they won't know that difference. Someone who understands insurance will. So that's the reason you want to have someone who knows the ropes and how to do that. The good and the bad is, to me, is this. The couple I said to you that this is an actual account. They're a couple in their 50s. They qualified for approximately $3.96 a month for two people. And their premium is actually $1,196. That's great. But the people live in a $400,000 home on a half an acre to an acre of land and have two beautiful cars. I don't know why they can't afford to pay insurance, but they did qualify. But again, like I said, there's the yin and the yang of it. The young man, he's getting almost all his insurance paid for, but he needs it. He's got nowhere else to go. Okay. Again, with the website, I've run into a different, strange problem every time I go to it. Yesterday, it was different, actually physically different than it was a week ago. I don't know why, okay, because the changes were not significant. But again, it's not too hard to work through. So no matter what you hear on the news or anything else like that, it is still workable. It is usable. It's not that difficult to get through it. And again, the people on the other side of the phone are very helpful. However they train them to do what they do was very good. Again, also remember there's exceptions to every rule. You can still get indemnity plans that do not qualify for Obamacare. You'll still have to pay the penalty, but it's an option. There's always options for you, okay? And again, as I said, like yesterday I had a husband and wife after I did the first one. They would not put them on the same plan. I have no idea why. They put them on separate plans. Same price when you add it together. Didn't make a difference, but it was just a different circumstance that we keep coming across. Okay? It's that simple, everything I explained to you. I don't want to go into heavy statistics and details, but the system is that simple to use. And again, you're buying insurance. Okay? I can go through all the rules, but no sense. Again, if you need to have anything more complicated, I can talk to you after the session's over. But that's basically it. You're still just buying health insurance. You're just buying it by a new set of rules. The rules are good for you. They might not be good for someone else. So that's the way it's going to work out for you. If you have any questions.
Okay. Thank you. As Hank mentioned, I've had a chance to be up here a couple of times before. And let me confirm for a moment, just make sure I understand who's in the audience. How many of you are physician practices? Okay, and the rest are service businesses that work with physician practices, correct? Good. Okay, that's helpful. I was going to bring my crystal ball this morning, but it had a big crack in it from the Affordable Care Act, because there's so much we don't know. So let me take you on a bit of a time travel this morning. Let's go back a few years, actually back 6 years, 2008. And at the time, I was working with a large primary care medical group, 25 physicians here in Seminole County. And one of the things that we were asked to do by the new administration at that time was to sit down and help them craft health legislation going forward. So we pulled our group together and we sat down in the room, and I remember looking at it and said, okay, so if you were to design the perfect system, what would it look like? Well, the ideas flowed back and forth, and we submitted them as requested to the administration, and we didn't hear back, and what came out was completely different from what our physicians really thought needed to be done from a primary care standpoint. And the interesting thing is, out of that, a couple of things occurred. One was that there were some options at that point in time, and I won't spend a lot of time on this, but one in particular HHS has talked to me about, and that is that if you think about the fact that we're trying to take care of the young invincibles, and the difficulty with the Affordable Care Act is trying to attract enough individuals that are young to offset those of us who are high users or users of services as we age, was simply to connect the requirement for health insurance to the access to credit. If you think about it, first time out, you're trying to get a car loan, you're trying to get a credit card, you're trying to get a deposit down on an apartment or your first home, and had we simply connected, as we do with auto insurance, the requirement that if you're going to drive, you have to have insurance, we could very easily probably addressed a good deal of this on the front end. The other suggestion made at the time was the fact, and I was dealing at the time, I had a health insurance agency. I was working with a plan out of South Florida. CEO of that plan said, you know what, there's 15% of the population in the U.S. that doesn't have coverage right now. If we just cut that in half, because probably half of them are not eligible for coverage, they're not U.S. citizens. So let's look at the other 7.5% roughly. He said, I'll sit down with all the other CEOs of the insurance companies in the state of Florida. We'll split the total number, and we'll just provide it to those who don't have it. Problem solved, very simple. But unfortunately, Washington doesn't work that way, and so they wanted to make it a little bit more difficult. And I think probably in listening to Nancy Pelosi's comment about having to pass it in order to read it and understand what was in it, and I did read it at that point in time, she was so correct, because in over 1,000 places in the legislation, it says the Secretary will. And as we have seen, Secretary Sebelius has been basically writing this as they've moved forward. I call it whiteboard legislation. And I do this from a realist standpoint, because to Mitchell's point, what was there yesterday may not be there by tonight, which makes it extraordinarily difficult for physicians and for other health providers, for those in the insurance business, to be able to figure out where is this thing going. So knowing that we're focusing again on physicians today, let's take a look at some of the things that has occurred. And I do need to share with you up front as a disclaimer that 2 of the 12 navigators that Mitchell referred to actually are employed by me. The Health Council, as an organization, a health planning organization, belongs to the board of the Primary Care Access Network, which is the network in Orange County that basically administers the program designed for individuals with no insurance. Now, there was some question back a year or so ago when we looked at this legislation coming out a couple of years ago and said, well, what's going to be the future of our organization? We won't be needed anymore. And that was before HHS came out with a realistic look last year, 1 year ago now, indicating that no, unlike the legislation was supposed to take it down to 8 million uninsured, pretty much those that would not be eligible in the U.S., no, indeed, the HHS projection now is 30 million without insurance despite the legislation. So given that, Primary Care Access Network will continue to operate and focus. And one of the things is the government came to them through USF and said, okay, we would like to fund 12 healthcare navigators for Metropolitan Orlando. And so they turned around to their members, including us, and said, would you put out some navigators? We've had 100% turnover in our navigator staff. Those that we hired got out there. They did get their certification. As you may recall, it took quite some time to do that. They had to go on overnight and early mornings and late nights to get through the training program. Once they did it, they found themselves, as Mitchell pointed out, in front of clients 3-4 hours at a time trying to get them enrolled in insurance. It got so frustrating that literally they all quit, and I had to start over. So the two that we did replace are with us today. And they do have a function, but also they have a function in working, again, outside of the traditional insurance model. So as we look at what's happened over the last 6 years, kind of moving forward, we are dealing with a very interesting look at where is the enrollment going. So far, according to the latest study, those 12 navigators have managed to enroll, and I have to be careful because they don't enroll. They're not insurance agents. They can only assist consumers in the registration process themselves. So far, the last count I heard was about 180 that they've actually done, which comes out to about $3,000 per enrollment cost to USF and ultimately to the taxpayers to get individuals enrolled through that Navigator program. The numbers dropped to nothing January 1 because, and this was across all the different navigators in the community, because most people felt they were going to be penalized anyway at that point in time. They didn't realize that they could go ahead and register through the end of March. The program is funded through August, and we'll see kind of where it goes from there. But what are the impacts on the physician practices that we're seeing as we deal with this? First of all, and this is not new, but the numbers of practices that we're finding that are either closed to Medicaid and now considering closing to Medicare as well has grown. So even as we look at trying to find ways to get individuals coverage, it's not reimbursing high enough to make it worthwhile for the physicians, because at the same time we have increasing cost of operating physicians' practices. And so there's a real squeeze there in terms of where will these individuals, once they get coverage, where will they go? And if they're in Medicaid today and they're not in Medicaid tomorrow, and those of you in physician practices know that people based on income and eligibility are in and out of these different programs. So we have a lot of switching back and forth that impacts the physician's practice because you have somebody who's Medicaid yesterday and not tomorrow. And so again, there's a tremendous amount of issues related to the fact that will practices be there to be able to serve those individuals who now are covered? We're also seeing a movement toward more concierge practices. And in other states, like Washington State, those of you who are familiar with the Q-Liance model, what we're seeing is movement to direct payment of physicians. So what you'll see is more and more physician practices moving into a prepay model. It may not be a concierge model. It may just be a fixed amount for $88 a month, $90 a month, whatever it happens to be. You then have eligibility for all preventive and primary services, and then you have a wraparound insurance policy that then covers those major outpatient and inpatient expenses outside of the primary care practice. That model is operating in, I believe it's 15 states now. Florida insurance regulations prevent it. Now, I do know a physician locally who's doing the model and doing it legally because they accept the payment at the end of the month instead of the beginning. So instead of prepaid medicine, okay, they charge for the physician, for the access to the practice at the end of the month, which, you know, for the first 30 days put them at risk, and then after that they're paid just after the fact. Florida does have, in its insurance regulations, a model called and don't hold me to the exact, it's limited prepaid primary care. It does require, one, that it be sold by insurance agents, and two, about $150,000 be available or stored in Tallahassee in case the physician should stop serving these individuals who have prepaid. But anybody who has an insurance plan can go ahead and offer this option, and I'm waiting to see Florida move into this. I believe that there's an opportunity for physicians, because if you look at then what the insurance covers, it can be a wraparound policy. It doesn't have to cover all the way down, and you're in essence removing the cost of the insurance, the third party, over a good portion of the delivery of the primary care model. So we're kind of watching that as we see and see if that concept moves in here. The other big thing that's impacting physician practices under the Affordable Care Act is narrow networks. On the insurance side, and you've seen lawsuits being filed around the country by physicians who have been basically crowded out or pushed out by the health insurance plans, those plans basically saying, okay, I don't need the broad networks I had before. I'm going to go to a narrow network and limit the number of practices that we have in that network, which basically carves out a lot of physicians' access to those health plans. So we're also seeing that impact. In a way, the physicians brought this on themselves. For those of you who are who remember or are members of the AMA and the AHA on the hospital side both signed on to the Affordable Care Act when it was first offered in Washington. And the reason they did it is because they thought everyone was going to be covered under this model. That, of course, was before the Supreme Court approved the tax that they call the Affordable Care Act. However, they did not require Medicaid expansion in the state of Florida. As you know, we're one of the states that did not choose to expand Medicaid in this model. So as a result of that, we also are seeing now, again, a very, very difficult time for physicians who thought everyone walking in the door would have some coverage under the Affordable Care Act and who don't. And what we're also seeing as a result of that is consolidation. It's not happening just in the hospital environment, it's happening in the physician environment. And my group was just sold, the group that I had been working with for 4 or 5 years in Seminole County was sold the 31st of December because the leadership of that group felt that they could not any longer see where things were going under the Affordable Care Act and couldn't take a chance of trying to stay in business under this, this new model. So it's also having a significant impact on consumers themselves. And here's where the greatest concern we have. If you'll move now from the last 8 years and what we're seeing currently to where we're going, that's of great concern to us. And the reason is we're looking at the model from Massachusetts. As a health planning agency, we spend a lot of time looking at where things are going. Recently, and my wife's a nurse and hospital administrator, recently we hosted a family from, came down for Disney from Massachusetts, of course, which is the home of healthcare reform, which has now been in operation there since 2006. They recently relocated, and her husband had to find a new medical practice, primary medical practice, so he called for his first physical with the new group. And they said, yes, we'll put you on the calendar 1 year, 9 months from now. That's when we can get you in for a routine physical. If you get sick in the meantime, sure, we'll see you, but you can't get on our calendar. 85% increase in the time it takes to get into a primary care practice in the state of Massachusetts. So our concern as a health planning agency under the Affordable Care Act and working with the medical community and the hospital community and public health is how will we manage access going forward? And that's of great concern, and where we're spending a good deal of our time right now is looking at three really different options to address that. The first one is technology. We're extraordinarily engaged right now in telehealth and mHealth, in triage apps, and a variety of different approaches in terms of technology. The second one is physician-led teams, and we're watching what's happening with scope of practice legislation right now. Will physicians be able to move up into team leadership in bringing on board case management, often nurses doing that, ARNPs, or whatever the new title may be, because they're looking at a reverse in those letters as they expand the scope of practice for nurse practitioners. Of course, that's held up right now in looking at it in Tallahassee. Community health workers and others who may very well fill out. Paramedics. We are working right now in 2 counties with EMS on using paramedics as part of the primary delivery model. So we're going to see teams, and then finally location. All of this technology in these teams focusing on moving care to the home if at all possible, and working with physicians in a completely new way with disease tracks and others to be able to provide services outside of the traditional walls. So that's, I didn't obviously, as Mitchell, who's an expert in the Affordable Care Act piece, address that today. I just wanted to give you an overview on a little bit of where we've come, where we are, what are some of the current concerns, and greater than that, where are we going and what will we have to be aware of as we move in that direction. Thanks.
Will do. So some of what you're going to hear from me is actually a repeat of what my constituents here have already said, but you know, it's very difficult when you start talking about the ACA to separate your personal feelings. How has it affected my family? My physician's office, my practice's feelings. How does it affect my patients, the operations of my practice? And then as an employer as well as a practice, how does it affect my buying health insurance? I've been affected on all three levels. And from a personal standpoint, last year I paid $12,000 for the year for my family's health insurance. This year I'll pay $24,000. That's a problem for me. And when you hear costs are going down, premiums are going down, this is going to be a good thing, it hits home when my costs have doubled. From an employer standpoint, when I'm looking at health insurance for my employees, I look at it and say, okay, well, what I could have bought them last year, I can't afford for them anymore. And the premiums are going up and the benefits are going down. When we say the maximum out of pocket is $6,500, well, that doesn't include the cost of the premium. So for my family, my maximum out of pocket is $40,000. You know, that's that. So all of this, it affects us in so many different ways. But I'm here to talk about how it affected my practice in a physician's office standpoint. So we're going to start with that. We all know that the goals, or the stated goals, of healthcare reform are improving the quality of care, providing increased access to patient care, lowering the cost of healthcare, and the stated was including the cost of health insurance. Now, the success of this is where we're going to start our measurement points going forward. It's going to be an interesting journey to see if they achieve any or all of these goals. And it's way too early to make that decision or make that estimate at this point. How does it change the primary care physician's office already? Well, PQRI started a couple of years ago, Physician Quality Reporting Initiative. So we now have metrics and measurements within the office that we must report on. We initially received incentives for starting EHR and for reporting these things to the government, to Medicare. My particular practice is over 75% Medicare. So that's you know, a lot of my background on what I'm going to be talking about. Meaningful use initiatives that affected our office as well. So we had initially a set of standards. You have to meet these specific things in order for you to be considered providing valuable information, providing total quality care. Things like BMI being, you know, high, low, in the middle, and then what are you doing about that? So some of it's very good if you think about the impact. All right, so we in the past, maybe a patient came in and they had a BMI of 32, and you noted that, but they also have high blood pressure, high cholesterol, multiple other comorbidities, and you said, okay, well, we're going to address these. Now you're required, if you have a BMI patient with a BMI of 32, to have a plan on how you're going to reduce that. So it's a good thing. It's a good thing for health care of the patient, and not a bad thing for us to actually be paying attention to that. So those are good things that are forcing some physicians' offices to pay more special attention to every detail of their patients. The other part that we're seeing now are ACOs, accountable care organizations. And my practice has joined one. It's physician-run. It's not one of the huge ones that is a business that then enrolled 200 physicians and said, you know, here's how you're supposed to manage your practice. This is 14 physicians' offices that got together. We have 6,000 covered lives, and we said, we know how to provide quality care. A businessman's not going to tell us how to do that. And we're all going to get together and say, you know, here's the best patient care for our patient base. But there's a lot of physician practices that are being forced into joining an ACO that are not as easily joined as our ACO was. Is that good or bad? We don't know. ACO started in 2010 with a lot of funding from the government. Our particular ACO got $2 million from the government to start its care, to start its planning. And we, this past year, were able to achieve about $100 per patient less cost than what their standard number is. I can't really tell you where they got the standard number from because it's a lot of math calculations that I am not qualified to talk about. But they said it should cost you approximately $1,000 per month per patient over the age of 65 with 2 comorbidities to care for them. And then there's different amounts depending on the comorbidities, how ill they are, and a lot of alphabet soup, which we'll get into later. But so we managed to do $900. And then they said, great, so that extra $100, we keep 50, Medicare keeps 50, and we give the ACO the other 50 per patient, which can amount to a lot of money. Unfortunately, if you have a few patients, all it takes is 10% of that 6,000 who have terminal illnesses, who have 3 or 4 surgeries, to use up every last cent. And in an ACO, unlike some of the replacement plans, there is not a cap on losses unless you buy a particular kind of reinsurance to cap your losses. So that's one thing. Other changes we've seen, lower reimbursements, capitated plans, Medicare reductions every year, more red tape for authorizations, increased limitations on approved medications. This is a kind of a personal favorite of mine. So if I want you on Singular, we'll use that one because that's a very common one. It's a great medication. It helps tons of people with their allergies and their asthma. It's no longer on almost any plan as a brand name. You must take the generic now. Now, as a physician's practice, why should you tell me what I can or cannot prescribe? And why should my patient be penalized because they need brand? Because, by the way, the generic only has to have 90% of what the brand's active ingredients are. So there are some people who generic doesn't work for, so you have to up a dosage in order to give them the proper amount. And it's kind of guesswork at that point. I don't agree with that. I think that if there's a medical necessity for a brand, you should have it. And absolutely unequivocally, there are plans now that will not approve the brand, no matter what, even for medical necessity. So that's kind of a, as you can see, hot button of mine. So what does all this mean for the PCP office? Is it lowering our costs now that we have more people who are insured? Absolutely not. I had to hire a new staff person just for referrals and authorizations because people are switching plans. We can run through our pre-authorization in the morning and say, okay, everybody has this plan, and they come in with a different insurance card. Okay, now let me call and let me find out how much their copay is, and do they have to meet the deductible before the copay? Is it just a flat copay? Do they have a cost-sharing plan? What do I charge them for today's visit? And believe me, a lot of the patients, once they leave your office, they're not paying your bill. They're not coming back. You have to collect that money up front. So it gets to be very difficult. The other thing that it means for us in capitated plans now, which is an interesting, so my constituent Ken here was talking about fixed cost or concierge medicine. The capitated plans pay the physician's office per member per month. Most of them are somewhere around $65 per member per month, whether I see the patient or not. Sounds great in theory, but since the capitated plans are all 65 plus, let me tell you, how many of them am I seeing every month? Every patient. So now I'm only getting $65 per patient per month, which in a concierge or a fixed cost model, when you have half healthy, half sick, is a great concept because you have access to care no matter what. You know that you've got my number, you can come in whenever you need to, and you're only paying your $90, $100 a month. And I know I'm going to see about half my patient base probably each month. Now I'm getting $65 per patient per month, and you might come in 10 times. I have people that I see every day for $65 per patient per month. it's a problem. It's not a benefit. And that's the replacement plans. I just went to a WellMed dinner on Tuesday night who hammered us. You can't send your patients to the emergency room. If you have high-risk patients on Friday, you better call every one of them and make sure they know you're there over the weekend. You'll answer your phone. Don't let them go to the emergency room. Okay, I have 400 patients on capitated plans. So now my new staff member who's doing pre-authorizations is also making phone calls. It is a burden. It is a burden. And then we're held to MRA scores, HEDIS scores, 5-star measures, HCC coding. We have to upcode. I actually had a plan who said to me, you don't really want to code this patient with this illness. You want to code them with this one because it's 2.1. No, I really want to code them with what they're sick with. So I had a plan who came to me and said, I have a 60-year-old patient with terminal cancer, and his oncologist said, you have one chance. It's probably not a good chance, but we can try this chemo. And the capitated plan said, you need to counsel him on hospice. You want me to tell my, you know what, you go counsel him on hospice. He's 60 years old. I want him to have that one chance. They don't. It's all about money. And that was so shocking to me and my staff that we were all just, when they left, we looked at each other and said, wow, how can they say that? They're not talking to the patients, obviously. So those are a lot of the changes that we see directly affecting my business, my pocket, my staff's pockets. Patient insurance issues. Now this is coming from our patient base. More patients do have insurance, so that's a good thing. But the insurance comes with some costs, higher deductibles, and in a lot of cases those higher deductibles are causing patients to not get procedures that they might otherwise get because they can't afford to do it. Higher copays, increased premiums for some, subsidized premiums for others, which I think is a good thing. At the same time, somebody's subsidizing it. And when does that money end? There's got to be a point when we can't afford that subsidy anymore. Medicare plans, you're stuck in a replacement plan. My practice just got terminated by PUP because we weren't making them enough money. And now I have 125 patients who can't come to my practice anymore, which Mitchell is helping me with, by the way. And those people in that plan who, by the way, in my practice, 75 were my patient before and switched to PUP on 1/1, and PUP terminated us on 1/15. And now they can't come to my practice anymore. And they cannot, if they don't meet certain criteria, they can't switch until next 1/1. Yeah, they can't switch midterm. So that's a problem. That's a problem for patients, for continuity of care, for the doctor's practice. It's just a problem. So the impact, and Ken talked about this a little bit, consolidating practices. The large groups and multi-specialty practices are growing, and the rest of us are all shrinking. And the reason for that is because as a single doc practice, we don't know where we're going. And it's scary. It's scary to see what's out there. Hospital-owned practices, there's been a 32% increase in hospital physician employment since 2000, and it's just getting more and more. Health plans are now buying up independent practices. You used to see Dr. Smith, now you see WellCare Dr. Smith, because they own that practice. Does everybody remember the old Humana HMO when you had the Humana Care and everything? Where are we going? Fewer physicians' offices. The physicians' offices are declining 5% per year since 2011, and it's just going to keep going down, especially for primary care. There's less and less and less. Access, cost, quality, those are things that we're trying to improve. I'm not sure that I see that direction going. Half of all physicians leaving residencies are employed by hospitals. They're being offered jobs by hospitals. Larger hospitals means larger leverage, which means higher costs. Only 11% of current physicians would recommend a career in medicine. This was a survey of over 75,000 physicians. Only 11% say this is a great job. 43% of physicians plan to retire in the next 5 years. Now, mind you, A third of those are over the age of 55 already. So retirement was coming. But 43% plan to retire in the next 5 years because of the uncertainty in medicine. A third of graduates from medical schools are primary care, 2/3 are specialists. Does anybody else say, wait a second, shouldn't that be reversed? And it's because specialties pay and primary care does not. There will be a 50,000 primary care physician shortage predicted by 2020, and that number is increasing, not decreasing. ACNs and funding for schools, area of critical need. They were supposed to be providing schools and funding for schools. That is not happening consistently. And they're not going to be generating the number of physicians that we need. So, are we lowering costs? Patients with high deductibles are deferring procedures, both elective and necessary, because they can't afford it. One hospital visit can drain somebody's savings account. 10 best-selling drugs are not under patent any longer. That's a good thing. That means that it is lowering costs because the copays are less and the cost of that drug is less. And new medical technologies are coming on board much more slowly. So that is cost lowering as well. Things are not as expensive. So there's good points. There really are. But from my standpoint, where I'm sitting, we see a lot more struggles than benefits right now.
Hank, I just want to make that. Yeah, I want to make one quick point. I didn't mention it because I knew Michelle was going to talk about it. When you get Medicare, there's the annual election period from October 15th to December 7th. The rest of the year is called lock-in. Except for special circumstances, you cannot change. The same thing is going to happen with the Affordable Care Act. You're going to have a certain period to sign up, and then the rest of the period time you're locked in. Insurance companies are not locked in. They can change and drop doctors anytime they want. We are on the bottom of the food chain.
All right, we ready to stump our panel? They probably won't be. We've got time for some questions here. Let's start right off here.
Well, I'm already stumped, so I'm confused at a higher level. But my question is from something I saw last night that Chuck exposed me to, and that's the idea of telemedicine. How reimbursable are those sort of efforts to cause a patient not to have to go to a hospital if they live remotely? So is that something that's coming whereby you serve a patient, but with the tools to do so?
If I can address that, I'm the co-chair of the policy committee of the Southeast Telehealth Resource Group out of Waycross, Georgia, which is the locally federally funded support office for encouraging telehealth in South Carolina, Alabama, Georgia, and Florida. We are looking at legislation pending currently in the new legislative session. It's been introduced House and Senate. There's a number of issues around that. Is it called telemedicine or is it called telehealth? That's a significant difference because the question is it supported? And it is supported by the FMA. It's supported by the Florida Hospital Association. But the issue is it open enough to allow the use of telehealth for individuals other than physicians? We have some significant telehealth that has been operating in the state of Florida for 10 or 15 years. The issue, to your point, sir, is the fact that right now we don't have parity reimbursement for whether a physician sees a patient face-to-face or face-to-face using technology, be that telephone or video in some manner. The encouragement or what we're seeing is a great deal of interest now in enabling that, because to Michelle's point of the numbers of primary care physicians short in this, 90,000 physicians short globally, and I don't remember your statistic. 50,000 primary care at a time when we have legislation that is encouraging the use of primary care medicine. So that will definitely be an issue, and the virtual delivery of care using telehealth will be a significant interest. I'm working with a physician right now out of Satellite Beach who works with all the major retail pharmacies nationwide, and they're looking at 4 years from now that when you walk into a Take Care clinic, or now they're calling them, I think, health clinics, or Care Spot, or any, especially the retail health clinics, you'll be able to see a specialist via telehealth in addition to your nurse practitioner taking, or PA, depending on the state, providing primary care in that setting. So we're going to see increased use of telehealth. The question of reimbursement is the thing that we're trying to deal with right now.
Great. Thanks, Ken. We have a question over here.
My name is Dr. Gonzalez. I am a pediatrician. I'm sorry, I am a pediatrician, and I see a lot of patients with Medicaid. So it is easy because it's straightforward. Either they are eligible or not. Now with exchanges, I was told that I will have a window of 90 days that if the patient doesn't pay their premium, it will show eligible. So I will be seeing the patients for 90 days, and most probably I will get paid for the first 30 days of visits. But then there will be 60 days that I won't get paid if the patient didn't pay the premium. I believe that that will affect the number of providers that later on will be accepting the exchanges. I mean, that's what I was told. Is that true?
Yes.
Yeah.
To put it simply, because I remember hearing the same thing, that a lot of doctors are going to be very wary, because they can go quite a long time, like you said, the 90 days, and they won't find out that they're not getting paid until after the fact. So yes.
And let me clarify, I believe the issue is the fact that the law allows you a grace period of time, so you may not have paid your premium during that time. In the case of where you're paying a premium, I'm not sure how that plays to Medicaid, but I know the hospitals in Louisiana were having a fit because, in essence, you know, they were treating somebody who they thought was covered, and then they find out that the premiums weren't paid and that there's no recourse for them.
And the other thing with Medicaid is the philosophy on why they think that's okay to do to doctors is because they just increase the reimbursement to what Medicare reimbursement is. So now if they don't pay after 60 days, well, but you already made enough money, right?
Very good. A question over here.
Thank you. My name's Rodney Douglas. I talk a lot to people that are in the borderline between being in your affordable care or whether you're in the poverty level. What is the breaking point in Medicare versus going to a regular paid program? Is it like a $16,000? You have to make more than $16,000, or you go into a Medicare program?
Well, Medicare is has nothing to do with your financial. You get Medicare whether you're in poverty or you're making $10 million a year. Medicare is for people over 65 and people under 65 under special circumstances with disabilities. So Medicare has nothing to do with your finances. It's only the Affordable Care Act subsidies. And once you hit 65, you're done with all insurance, regular insurance. You go into Medicare automatically. Nobody over 65 has anything to do with the Affordable Care Act, and nobody under 65 has anything to do with Medicare unless they have disabilities.
I really enjoyed this, very enlightening. I know, Mr. Peach, you said 180 people were enrolled by the Navigators. Do you know how many people have enrolled in general? And without people enrolling, don't you think the system isn't going to work as designed?
The number, I believe we all saw in the headlines yesterday, 4 million. I believe that's what the administration announced yesterday, had now actually bought insurance. And I think that's the difference. The Navigators have seen many, many individuals, worked with many individuals who get to a point and say, you know what, I'm not going to continue this process. And so in large part, it's not that the large numbers of people aren't looking at this. The indication, I'll tell you, the first day that, that this opened, I believe it was October the 1st of last year, I was sitting in one of the registration points with the Navigators watching. And what we were getting were two things. One, individuals coming in who already had coverage, who were looking to save money by switching over to the exchanges. And then the second thing is we saw a lot of people come in who were definitely in need of care. And so you have those individuals who have had either impossible or difficult to be able to get insurance, who were the first ones in line to sign up. Those are the individuals that are cost the system the most amount of resources, and therefore you have to have the balance. There are two pieces of the Affordable Care Act that are safety switches, that if it gets into what's called the death spiral for the insurance companies, and they don't have enough healthy people to offset the cost of those individuals that are ill, there's an allowance here for the Care Act to, in essence, pay the insurance companies for the fact that they are in this situation to offset those losses. The question is what will happen. It was put in there with the idea that, okay, if that occurs, this way we can continue the Affordable Care Act. So while we've seen billions of dollars put into this already, we may see many billions more in order to keep this thing afloat if indeed that occurs.
The number was 60,000 and it's been changed to 45,000. So when the insurance company pays $45,000 a year bill, the government's going to stand in and give them a subsidy. So everybody's getting a subsidy.
And let me just one other thing. HHS now has changed twice since the USF grant went into effect October the 1st, has changed how they measure success of this enrollment process. So what's happening is they're trying to find ways to make sure that the projected success of this plan is measured and illustrated as this is the way we want to see it done. So when you change the measures on any program, and we do a tremendous amount of program evaluation at the Health Council, you get a little concerned.
A question over here.
Michelle, you mentioned that PUP declined or took you out of their system. Were they required to give you any notice at all? Or, I mean, I would assume that you were supposed to get some notice so that the patients could recover and your practice could recover and help them. Was that given to you?
Yeah, so the standard is 60-day notice, and they terminate at the end of the month. So we got notice, they mailed it out on January 15th, and they gave it us until March 31st. There's one provision that we can appeal that decision. In our particular case, we had 125 members, 45 brand new, only been with the practice for less than 4 months, and 3 of them were driving the entire cost. So we have appealed the decision. However, that being said, the same day they mailed us our notice, they mailed it to every one of our patients. And let me tell you how many phone calls that generated from patients very mad at us for terminating our contract with PUP. Whoa, we didn't terminate anything. So yeah, you do have an opportunity to appeal. You do get 60 days. If you lose the appeal, you have 6-month sit-out time. So we cannot participate in PUP for 6 months from the time that we got terminated. And by the way, we don't go, practices do not go to these plans directly. We go through a third party, an IPA, and whichever they're calling themselves. And that's who actually terminated us on behalf of PUP. So yeah, it gets interesting.
And if you don't mind, I'll tell you from your point of view, you're going to get a letter from someone like PUP, and that says, we've changed your doctor, here's your new doctor. They're going to pick your doctor for you. And or you get a letter saying, you no longer have coverage. They're not going to say that. They won't even tell you, oh yeah, you can switch, you can look around. Because I've gotten calls from people saying, Mitchell, I'm not covered anymore, I don't have any more insurance. And I try to tell them, it's a form letter, you can switch, you do have time. But they're just sending you a letter saying, this is what you're going to do, we're telling you. So.
All right, we're coming down to the end of our morning. A couple last questions. Bernadette.
Hi, this question is for you, Michelle. I hear you talk about your staff, your employees, and I hear the passion that you have for them. How much do you educate your staff to get the buy-in for the struggles that the facility is going through? And do you find that information in educating your staff on the why to increase and maximize the what they do and how many hats they have to wear? Do you feel that that's a very necessary implementation?
Absolutely. The staff know exactly what's going on probably 2 days after I know. They need to know what's going on, how they can help the patients, and I'll give you an example. One of the things that we do for Medicare is the annual wellness visits, which is completely different from an annual physical. And the staff came to me and said, but why are we doing this on capitated patients when we don't get reimbursed for it? Well, it's good health care. So that question prompted me to say, okay, we need a lunch and learn. And the more they understand why they're doing their jobs and why we're still struggling and why I can't give them $400 a month for their health insurance, the more they actively participate in the practice and in the progress of the practice. So yeah, I think that staff cross-training them and staff education and keeping them abreast of all of the situations is very, very important.
And we're down to our last question of the morning.
Hi, this is Nathan Meeks. I have a question in regards to the insurance companies buying physician practices. One, how is this not a conflict of interest? And two, it seems to me to be a vertical integration monopoly where you will no longer have basically competition for health providers.
Well, for one thing, they make sure they only own a certain percentage. I believe 49%. This was an instance I spent a few weeks last year in Jacksonville. Humana owns a bunch of doctors' offices, ACOs. So they dropped all the other doctors they had and it left 3,000 patients during lock-in, which means they couldn't change their plan unless they had special circumstances. Humana just happened to have a doctor's office directly across the street from the one they dropped. So it was convenient to switch and move over. But the basic answer to your question from our point of view is they only own a certain percentage, by law, whatever it is, I think 49%, so they're allowed to do it. And as Ken and Michelle mentioned, a lot of companies are starting their own, are buying their own doctors. So the insurance company owns physician practices, the hospitals own physician practices. So they've cornered the market. Yes.
Yeah, if you look back at 1995, I was with the AHA and the Florida Hospital Association. We did a micro-world simulation for 2 days with hospital CEOs and board members from around the state. That process led to the most successful outcomes being those physicians or those CEOs who had 3 elements in their portfolio. That is a hospital or hospitals, physician practices, and an insurance or payer component. Okay? One of the individuals participating was Mike Means. Any of you who might know Mike, he went back to Melbourne, Florida. They ended up expanding to 4 hospitals. They bought MEMA, the largest internal medicine group in Brevard County, which they now own under the same umbrella, and they went ahead and created the Health First Health Plan. They have huge market share in Brevard County, and now Florida Hospital learning the lesson at one time of how expensive it can be if you run a health plan that's out of control, and they've admitted when they ran their Medicare Plus Choice plan, they burned through about $30 million in 1 year. Hey, this is not so bad, let's link up. And so what you will see is the introduction of the Health First Health Plan, first in Volusia County, where it's being tested right now, and then into this metropolitan area. So you have the 3 components. You have the hospitals, the physician practices, and the health plan all under one umbrella. So that's what you're going to see in terms of movement. You're seeing consolidation, hospitals now linking, Pittsburgh, where you've got health plan buying hospitals. So yes, I think that's what you're going to see in the whole movement of consolidation. One risk there is those individual physicians who ran under the umbrella of the hospitals. Right now, some hospitals are having their bonds downrated because it's taking them so long to turn those practices around and get their investment back that it's actually impacting them financially. So there is that risk that those physicians who saw that as a safety zone of working for this large organization, the deep pocket hospitals, may live to regret that yet.
Well, let's give it up for Mitchell Gordon, Ken Peach, Michelle McCormack,